Pilonidal sinus treatment combined with Lepsit. As in the country of Trump, they say, blow your own trumpet. So this is my introduction. And I'm a fellow of, as well as EC member of Association of Thoracic Surgeons of India, and on behalf of the ACSI, I'm presenting here Pilonidal sinus disease. And if, dear friends, if we see the whole plethora of surgery in Pilonidal sinus, it can be just excision of the disease and let it heal by secondary intention, which takes almost 54 days. If you apply back, that decreases the time to 5.4 days. You can do primary closure with a midline closure with a significant risk of recurrence with 16.8%. You can do off the midline closure, but with again a significant risk of 10.8% recurrence. And there we now move from a flap to a no or the minimal excision to a simple minimal procedures like phenol application, sinusectomy, lay open, etc. But coming on to the endoscopic, under endoscopic vision and a visual guarantee of removing the damage. What is the clinical dilemma and what is the shifting paradigm? Why MIS in PSD? There is significant morbidity and recurrence of this disease even after traditional invasive surgical techniques, and you can see on your right side, the upper, a larger wound for a very small disease. And then in the lower film, you can see that after a flap, there is some wound morbidity and recurrence of 10% still occurs. MIS reduces this morbidity. MIS results are better or at least comparable with traditional surgery if you think about the time of the work. It's a disease of young people from 16 to 40. And every day counts. Either they are in education, or they are in teaching, or they are in the whole-time job. So the results are better with MIS. MIS demonstrates efficacy in eliminating the factors. What are the factors? Pit, a cleft of the hair inside. Now it doesn't deal with the deep cleft, but it deals with the pits in the hair. And dear friends, the desired goal is procedure should be simple, painless, with a rapid healing and no recurrence. But we have still not achieved the duck recurrence. Friends, see this. Don't you think it's an overkill for a subcutaneous benign disease that you excise so much of fat and skin? All these procedures we used to do earlier with a flap, with a Limburg or a Baskin, now can be done simply with an endoscope and a laser if applied together, and with almost same results as far as early outcome is concerned. Though the long-term results of 20 years and so are still awaited. And we acknowledge the global push towards MIS for PSD. There are Delphi consensus for that. And in our own series, we see that only 7% of the cases they need a flap. All other cases they can be managed with minimal access surgery. From the pit stop study or from the Seco in the deep, this article on Delphi in Epsit, everything says that we should do more and more minimal invasive and especially endoscopic. But everything is not that rosy. You see, standardization of technique is still not there. There is a lack of high quality data, learning curve for the surgeons, initial cost to the surgeon. But the most important thing, how do we objectively choose between an MIS and a major tissue flap without relying just on the sheer intuition of the surgeon? And there comes the role of our classification, called as singular method classification, where to do and what to do. These are the indications for the Epsit or the Lepsit. Pits with lateral tracts, single pit in the center, small lateral tracts. You can lay open, you can do sinusectomy, but in the modern era, we say endoscopy visualization gives you the guarantee of removing everything under vision. And this is called as 1A. Another is, which is the most common presentation, there are midline pits, multiple midline pits, the lateral tracts, the indurational of an abscess, all these things, they can be easily managed without any flap with the help of an endoscope. Okay, so we have demarcated. If there is a midline wound more than 1 centimeter in size, or there are certain atypical situations where you need a flap, all other things can be managed with the help of an endoscope. Even after recurrence, as you see in this case, there is a recurrence after Z-plasty, there is a recurrence after Limburg flap. Even if there is no midline wound more than 1 centimeter, you can still put in an endoscope, can remove the missed hair inside or the debris, and even new pits are also formed with passage of time. That we should understand, because supposedly you have operated in a case at the age of 16, by the age of 40 he can develop new pits. So that is another concept is coming up. It is not actually the two recurrence, it is the new disease, and there also the endoscope can help you out. A midline wound more than 1 centimeter, or the pits are so large that you excise it, it will create a wound more than 1 centimeter. As you see these slides on the right side also, these all patients need a flap at present. And these are certain unusual cases. You see a large big perianal ulcer, suspecting fistula. You see a hypertrophic granulation tissue or a pedunculated mass in the midline. Or you see on your right side an extensive subcutaneous network of cracks, and this case was managed by keratitis. Here your endoscope is not going to help you out. These are the cases called as atypical cases, and which we usually will see less than 1 in 100 cases. They need a flap as of today. Patient has been operated and the definite surgery was done, a midline closure, something like that, it ruptures out. The best is managing it with a vascular flap. So dear friends, R is the word first classification to systematically weave endoscopes and laser into the core treatment algorithm. There is no difference of opinion about P0, PM and PA, means minimal disease or abscess, but for P1 means when there is no midline large wound, you can do Epsit or Lepsit, or with a large midline wound more than 1 centimeter, you can do a flap, and same is for the recurrence. Dear friends, the takeaway message from this part is standardization eliminates surgical guesswork and protects the gluteal cleft architecture. And if there's a marriage of endoscopy with the diode laser energy, if Epsit is the vision, then laser is the engine. We move from a blind track destruction to the visual guarantee of complete debridement, and there's an evidence for that which has been given in the footnotes. For equipment part, for endoscopic knee you need a mineral endoscope, which is 18 centimeter long, and it has a small 4 millimeter diameter, 3.3 to 4 millimeter. You have an endo brush, you have endo forceps, you have a buck electrode, you have a camera, and you need a light source with the light cable. In addition, when you join it with laser, you need a laser machine, 1470 diode laser at the rate of 10, strength is 10 watts, energy. If you're doing it blind withdrawal, you can withdraw at the speed of 1 millimeter per second, but if you're doing it under vision, under the scope, you can do targeted fulguration, a radial fiber on your right side, and on your left side of the screen you have punches. You need not excise with the blade, you can just punch it out the pit. And there is a brush in the center, endo brush, as well as this brush will remove the batteries. And let's have a small video to show you how we do it. Position of the patient is prone position like this, straps to open the cavity, we take the picture, zoom it, try to find out the communicating with the help of the dye. Scope should be a little acute because obtuse will destruct the damage. You can dilate the track, you can excise the track, and here you go inside to the diagnostic phase. You see the granulation tissue. Beautiful as you see, as you progress further, you allow your normal saline or glycine if you are using the cautery. And here you see the hair also inside. And now the therapeutic phase starts. I am putting an endo brush inside, and endo brush will, it's a good idea to rotate it, not to just do to and fro movement. And this will entangle everything into it, these fibers. After the removal of the hair and debris from the track, you see the beautiful cavity inside, but still there are certain shreds. And laser will ablate this cavity well. As you see here, we have put the laser fiber 1704 radial, and keep the tip 1 centimeter away from the scope, otherwise you will damage your scope because of the thermal injury. And then you fulgurate it with the blind withdrawal at the speed of 1 millimeter per second, but still there are certain areas which are not touched, and that's the skip areas. Even if you do blind laser, there will be skip areas. Here, you remove those skip areas under direct vision. You fulgurate those skip areas, and later on use the curettage should be very thorough, and curate the whole cavity. You punch the pits with the help of skin punch, and you will see that after that, Now you thoroughly lavage it with hydrogen peroxide saline solution because that will remove, and you see the beautiful cavity inside. There are no more granulation tissue, there are no more hair inside. Here at one place I have broken the tract. It doesn't matter if you do it at the end of the surgery. In the beginning you may fluid may disrupt. This is an optional thing. You can do suturing, you cannot, but you may not. But here, because it was a secondary case, the skin was not very supple, so I did suture. And you take the suture with straps, but when you apply, you tie the suture, you remove the straps, and this is the healing beautifully. On 18th day stitches are out, so the patient is without any dressing. Certain tricks. If you disrupt the tract, you will see that cobweb appearance. If the cavity is full of hair, you take the endo forceps and remove the hair slowly and gently. And if still there is a lot of hair, you cannot just enter. Take the artery forceps, rotate it again, and you can take the whole pilus out. And that's a beautiful idea of that. And I tell you, not only this type of cases, but cases where there is a cavity like this, you can see on your left side that is the caudal, that is the cephalic end, and on your right side is the caudal end of the patient. You can see this video, and patient is again prone. You can create certain openings if you have only one opening, especially in these type of cavities, and you can debride the whole thing. You can remove the hair from inside, and you can then see the cavity inside. You will see a good tuft of hair at times, and you see this is a beautiful tuft of hair. You can see here inside. You can just catch a hold with the endo forceps. You apply the endo forceps, and again you rotate the endo forceps. Okay, when you rotate the endo forceps, everything entangles with it and it comes out. So that's the idea. You may not use the laser in pus, but once you drain the pus, you curate it, thoroughly lavage it, you can still ablate the tract with the help of laser. But never put laser in the pus, because of the so many properties of the pus are different from that of blood and water, and there can be stagnation, there can be damage. But you can still fulgurate the wall only after thoracocurettage, then there is no damage. And you can just put the scope inside, see everything is clean, and now you can fulgurate this is the wall of the cavity. Yes, of course, when you are fulgurating the wall, it becomes very little tedious because you have to do at many places you have to do that. So that's why there are few papers which say that if there is any advantage of adding laser after curettage, we will be talking about that in a few minutes. And after doing this, clearly we are doing now it with the laser. Yes, but don't put laser fiber direct in the pus, but you can ablate the wall cavity. And here, because of this skin was very stuck to the sacrophagia, so that's why I just removed that sacral fascia attachment to the skin. And after this cavity, you can apply these stitches and there's healing beautifully. After 4 days, you can see this. And we put a sterile earbud to see that there is no premature closure of these tracts. And this is on the 8th positive day. And this is the selfie sent by the patient, showing us that they can do it even at home. And thereby, after this, our experience, we have come to a conclusion that in this type of case, you see on your left side, all pits, multiple, and there is a small sacrococcygeal pit at the base. In this case, instead of doing a whole flap, what we did, we managed the above pits which are communicating with the help of endoscope. And for the smaller pit, we just created a small flap. This is what we call as a hybrid approach. A young lady of 18 years, and there's a complete healing after 14 days, as it is in this case. And maintaining the architecture of the buttocks. And dear friends, I'm happy to share with you with this. This is our publication, and we show that 88% of the cases they can be simply managed beautifully with the help of endoscope. 7% is purple, actually they need flap. Others can be managed with the hybrid approach, and our recurrence rate is only 2.4% case in the initial 2 years. But as the data will accumulate, we understand that the recurrence may increase because at many times after a few years, the recurrence increases. What about, this is what I say or we say, what the medical literature says. That if you compare with the laser endoscopy with the phenol, then the rate of sitting on the toilet is comparatively without any pain is better when you do with the laser. When you do a laser endoscopic assisted short-term results have better wound healing and patient comfort and a shorter return to work. And when combined laser therapy is not an essential part of the endoscopic treatment. But I tell you, dear friends, combining endoscopy with the laser is an essential component. I mean to say that you should always do the visual guarantee to yourself and to the patient that you have removed every debris and every hair inside, then laser ablation. And there's another study to compare the laser ablation with flap and other things. Still, they find that laser has a reduced risk of complication, but the residual disease is more. Residual disease is more when you are using laser without endoscope. And the beautiful article that is there really any advantage after the curettage adding laser? And still, we are also confronted with this. And dear friends, now that's your Now it's your choice how you have your war against PSD. Whether you do a carpet bombing, remove everything and do a flap with its morbidity. Whether you are targeted bombing with pit excision, what Biller did, and whether you are vision guided precision targeting with a laser bomb, with Epsit, with Select and Lepsit. Dear friends, you have to choose. I have shown you the results. And if those who want to deep dive into the case studies, energy settings, and complete photographic step by step, you can refer to our manual on operative manual of minimal invasive and laser and pathology. And I'm really thankful Malaysia. I'm here to present you, and if there are any questions, I will be happy to answer. Thank you so much.
Thank you, Sanjay. That was a riveting presentation. Really open up your mind. And it's a pilonidal sinus is a subcutaneous disease. And when we're doing flaps, yes, flaps are required, and when they're required, you have to do them. Since I have a large group of trainees, over 1100 surgical trainees, I asked them to show me the initial photo before they did the flap. And believe me, most of them have only tiny holes. And why are you doing such big surgery when you can get away with minimally invasive? That's the point we want to make. So going for minimally invasive first, and then think about flaps when that fails. And in my experience, 50% of my patients are recurrences after flaps, and they can all be done by minimally invasive surgery. Now coming to the scariest part of this whole presentation, that is complications. Complications which you don't see on the table, but you see afterwards. So Dr. Kamal Gupta is going to come and talk about complications.